Now I'll start class, and today we'll discuss on the management of cataract. Okay, so in previous class we have discussed what is cataract, how cataracts are being formed, what are the clinical features, and what are the once you diagnose cataract, what are the pre-operative evaluation you do, and what are the pre-operative investigation which are done before the surgery of cataract. Okay, so today we'll discuss on the management of cataract. Can you see my screen or not?
Yes,
Can
ma'am.
anyone answer me, please? So you can see my screen, yeah?
Yes, ma'am.
Okay, so we'll discuss on the management of cataract. Okay, so once we get the case of cataract in our OPD, okay, so we have to evaluate the case, okay, to see the extent of visual impairment. So how much visual acuity has been impaired, and is it affecting their daily activities or not? Okay, because for surgery there is no assess visual indication. Okay, there is no visual criteria to go for surgery. So this must visual acuity we have to go for surgery. There is no such criteria for surgery. Surgery is indicated whenever the patient complains that this cataract is causing him the difficulty to perform his daily activities. Okay, so it depends on profession. For some people, it doesn't matter to them until the vision is hand movement or even if it's PL, if they are old and are retired. But if he or she is a pilot, or if he or she is in some profession where there is increased visual demand, then the patient may complain even in the visual acuity of 6/9. So there is no such indication or visual criteria for cataract surgery. So surgery is indicated whenever it is hampering his or her daily activities, then we have to go for surgery. Okay. So there are basically two types of cataract surgery. One is intracapsular cataract surgery, and another is extracapsular cataract extraction. And this intracapsular cataract extraction is obsolete nowadays. Okay, it's now not practiced anymore. Okay, because it is related with high rate of complication. So we don't practice it anymore. It's obsolete. So you just have to know that previously, okay, a few years, 13 years back, okay, people used to practice that surgery, but now they don't do it. Okay, so what we practice nowadays is extracapsular cataract extraction. And in extracapsular cataract extraction, we have different types. Okay, the one is conventional. The conventional one is where we do is an open technique where we make a large incision and then we suture it. Okay, that is conventional one. Then the recent one is small incision cataract surgery. Okay, you make a closed chamber, small tunnel shape incision. Okay, and then it's a closed chamber technique. Okay, and the wound is self-sealing, so you don't have to suture it. Then there is phacoemulsification. Okay, this is a newer technique which is practiced in Nepal, that is phacoemulsification, where we use the phacomachine to emulsify the cataract. Okay, you don't have to extract the nucleus. You don't have to take out the nucleus. You just emulsify it within the bag. Okay, then there's another technique. This is a recent advanced femtosecond laser, which is not practiced in Nepal, but in developed countries, they use the laser to emulsify the cataract. Okay, so you need to know something about the intracapsular cataract extraction. So what does it mean? The intracapsular cataract extraction means it means that the cataract lens is removed as a whole along with capsule. Okay, so I have told you in previous class in anatomy that the parts of lens are capsule and nucleus and cortex. Okay, so the nucleus and cortex are enclosed by a capsule. So in intracapsular cataract, what we do is we remove whole of the lens along with the capsule. So what will happen if all the whole of the lens is removed along with capsule is that there will be no space or no place to implant the intraocular lens. Okay, so the patient has to lift a phakic, or either we have to put the lens in the anterior chamber. But since the whole lens So which structure lies behind the lens? Where does the lens lies? What is the position of lens? Can anyone answer me? So in my previous class, I've told you that it lies between the iris and vitreous. Okay, it is suspended structure between iris and vitreous. So in posteriorly there is vitreous. So if we remove whole of the lens, the vitreous will be disturbed. Okay, the vitreous phase is disturbed. So which may lead to complications like vitreous traction, ultimately leading to the retinal detachment. Okay, so this technique is it is accompanied with lots of complication. Okay, so we don't practice it anymore, but then in certain cases we may need to do it. Okay, just like in subluxated cataract, okay, a subluxated lens or dislocated lens. In those cases, sometimes we may need to apply this technique. Okay. Now we'll discuss on the extracapsular cataract extraction. The whole term, what we do is the whole technique is that we do extracapsular cataract extraction along with posterior chamber or posterior capsular lens, intraocular lens implantation. Okay, so PCIOL. Okay, so the posterior capsular intraocular lens implantation. So what we do in this technique is that we remove the cataractous lens, mainly nucleus. Okay, and all the lenses are sorry, all the cataract is removed, but we leave behind the peripheral part of anterior capsule as well as posterior capsule. So if you remember the anatomy, okay, it is enclosed by the capsule. So what we do is that we make an opening in anterior capsule. Okay, through that opening in the anterior capsule, take out all the cataractous material. Okay, and then what is left behind is the peripheral part of the anterior capsule and the posterior capsule. So what will happen is that the intact bag is left behind. The tonule is not disturbed. Okay, the vitreous is not disturbed, and the bag is there. So what we can do is we can implant the intraocular lens, okay, in that bag. So the patient will be pseudophakic in this case. Okay. So the indication for this is that in all the patient, okay, so goes under intraocular surgery and who are planned for posterior chamber intraocular lens implantation, we use this technique. Okay, so it is contraindicated in subluxated and dislocated lens. We said that, okay, but then in newer technique, okay, with advance in the surgery technique. Now, even in with the subluxated lens, we apply intraocular lens, sorry, the extracapsular cataract extraction technique. Okay, even in subluxated lens, we can use the technique of extracapsular cataract extraction nowadays. So what is the advantage of extracapsular cataract extraction is that it's a very safe procedure and the complication rate is very low because donor is not disturbed, vitreous phase is not disturbed. Okay, and it's the easy technique. It can be done in all the ages, and the most important advantage is that we can implant the posterior chamber intraocular lens in this technique. Okay, so patient will be pseudophakic and the patient will have good vision on the very next day. Okay, so the visual recovery is very early. Now in the technique of extracapsular cataract extraction, we are going to discuss on the small incision cataract surgery. Okay, with posterior chamber intraocular lens implantation is a type of extracapsular cataract surgery, as I said earlier, and this is very safe and sutureless technique. Okay, it's a very safe technique and it's a sutureless technique. So what will happen is that the patient will have, we don't have to suture, the patient won't experience any kind of foreign body sensation, and it's a time-saving procedure. You can finish a surgery within 10 minutes. Okay, it's more, so this is very, and it's cost-effective also because we don't need to use suture. Okay, so this is very there are lots of advantages in this surgery technique. So what we do in this technique is that we either give an incision which is straight or front shape, and the incision is about 5.5 millimeter to 6.5 millimeter. Okay, and usually the incision is given 2 millimeter behind the limbus, and then what we do is scleral tunnel is made. Okay, so that we can enter the anterior chamber, and that's how we extract the cataractus lens. I will show you the video later. Okay, so this is only the theory part which I am discussing. So what is the advantage? Because you may have questions, okay, SAQs on these techniques. So you need to know something about these surgery techniques, okay? So advantage is that it's very fast procedure. I said that you can finish up surgery even as early as 10 minutes, and the visual recovery is very fast. Very next day you may have good visual acuity, and the incision is so small, okay, and there is no such a related complication. The patient won't have any kind of foreign body sensation or tearing on the next day, and there is the post-operative astigmatism won't be much in this type of surgery. But the disadvantage of this kind of surgery is that the learning curve is very high. Okay, so it's a closed chamber technique, and then the surgeon need to expertise in this procedure. Okay, so they need to learn this surgery, and the learning curve is high among some surgeons. And then the chances of fissure is always there in any kind of cataract surgery. Okay, because it's a physiological phenomenon, but we have to mention it. Okay, now another technique which we practice nowadays is a more advanced technique is the phacoemulsification. Okay, so in phacoemulsification, the incision is even smaller. Okay, you just have to give incision about 3.2 mm. Okay, 2.8 to 3.2 mm. So small incision. So in that incision, with that small incision, what we do is we have to insert the foldable iron. We have to fold the intraocular lens so that it is implanted. Okay. So it's in this technique we have to use the take the help from the phacoemulsification machine. Okay, but the cost of phacoemulsification machine is very high. Okay, it's very costly machine. So the cost of surgery is also more for the patient. Okay, so this is costlier technique, but the advantage is that this incision is very small, and this, of course, this is a sutureless surgery and it's a step procedure. Okay, so since this is a closed chamber technique, the anterior chamber is maintained throughout the surgery. Okay, and since the incision is so small, okay, the post-operative astigmatism is also very small, and the visual rehabilitation is very rapid. But the disadvantage is that, as I said earlier, the cost of machine is very high. So for the patient, the surgery costs much, okay, for the patient. Okay, for small incision surgery, we charge only 5,000 to 6,000. But for phacoemulsification, the charge is very high. Okay, it may cost them 25,000. Okay, and the learning curve is also very high for the surgeon. Okay, because we have to we have to understand the machine. We have to know how it is done. We have to know about the ecodynamics, the dynamic of the machine. Okay, so the learning curve for the surgeon is high, and there may be complication. There is possibility of complication in hard cataract. Okay, since we are doing the surgery and we are manipulating the nucleus within the back, within the anterior chamber. So while manipulation, if the cataract is hard, then it may compromise the cornea. There may be chances of posterior capsular tear and rent, and so that the nucleus is dropped in uterus. So there's chances of complication in hard cataract. Okay, the recent one is femtosecond cataract surgery, but it is not practiced in Nepal till now. Okay, so maybe in your generation, you may get to see this femtosecond cataract surgery. Now once we know about the cataract surgery, okay, so once we have made a choice on which surgery we are going to do, now we have to prepare the patient for the surgery. Okay, so what are the pre-operative preparation for the surgery? Okay, so once we say, okay, tomorrow you are going to have surgery, what we have to do is that we have to prescribe the patient the prophylactic antibiotic. Okay, so we don't want any kind of infection post-operatively, so we give prophylactic antibiotic. For that, what we prescribe is we prescribe ciprofloxacin 0.3% or tobramycin. Okay, so we instill it 4 times a day prior to the day of surgery, and we even prescribe topical NSAID to prevent the inflammation. And on the day of surgery, before cataract surgery, around 30 minutes before, we have to dilate both the pupil. Okay, so sorry, we have to dilate the pupil of the eye to be operated. And to dilate, we use the medication propicamide and phenylephrine. Okay, so with the help of tropicamide, do you know what is tropicamide? It's a mydriatic drug. Okay, it's a drug which helps in mydriasis, and along with phenylephrine, we have to do the pupillary dilatation. Okay, then now we have to give anesthesia. Okay, so for anesthesia, it's a regional block anesthesia. So either we go for perivalvular technique, okay, perivalvular anesthesia, or no, retrovalvular anesthesia. What we in anesthesia, the agent we use is 2% lignocaine along with bupivacaine. Okay, so we use short acting as well as long acting anesthetic agent. Okay, and we inject the anesthesia in the either in the perivalvular space, that is the space around the eye globe, or retrovalvular, that is the space behind the globe. Okay, so we have to inject the anesthesia in that space. Okay, so once you give anesthesia, and then we have to press the eyeball so that intraocular pressure is not raised. Okay, then after the anesthetic, the effect of anesthesia is there, then we have to give the incision. To give the incision, first we have to do peritomy. The peritomy means that we give the incision in the conjunctiva. Okay, so we have to cut open the conjunctiva. So if you can see here, this is the pinkish structure with basis. This is conjunctiva. So what we have done is that we have cut the conjunctiva and retracted it so that the sclera is exposed. Okay, so in the sclera, we give the partial thickness. Okay, we don't go for full thickness. We go for partial thickness incision, which is 2 millimeter behind the limbus. Okay, and this is a frown shape incision. Okay, so you can see it's a curved incision over there. Now what we do is in this partial thickness incision, we create the tunnel. Okay, so we make a tunnel, okay, extended up to the 1 to 1.5 millimeter of the cornea. Okay, so we can see the blade over here. Okay, so we make a tunnel. Then once the tunnel is made, we can see the internal incision is made in the cornea. You can see here the cornea is entered from here. Okay, with the help of keratome. Okay, so you cut open the cornea so that you enter the anterior chamber. Okay, now once the anterior chamber is open, what you do is we make a opening in the anterior capsule. So in this case, the anterior capsule has been stained with dye. Okay, that is Tiffany blue dye, so that it is stained blue, so that it is easier for surgeon to visualize the capsule. Okay, now this capsule is turned open. So you can see here the capsule has been open, and this is the cortex and the nucleus that is being seen, and this blue one is the capsule. Now, after that, we have to do hydrodissection. Okay, so with the help of now we have to inject the water or the balanced saline solution in between the capsule and the cortical material so that it is separated. Okay, the nucleus and the nucleus is separated from the capsule. Okay, so once it is separated, we have to rotate it, bring it to the anterior chamber, and then we have to take it out. Okay, from the eyeball. Okay, that is called nucleus delivery. So you can see in this picture, the nucleus, this is the nucleus. Okay, it has been delivered through the incision. We have taken out the nucleus now. Now, the cortical matter, you can see the whitest part, the opaque parts. Okay, so this part are aspirated with the help of irrigation aspiration cannula. Okay, so from one port you aspirate it, from one port there is irrigation, continuous irrigation is going on so that the anterior chamber is maintained. Okay, the anterior chamber should be maintained throughout the surgery, otherwise there will be damage to the corneal endothelium, which may lead to corneal edema. Okay, so once this thing is clear, now the posterior capsular back is clear. Now we have to implant the intraocular lens. So you can see this is intraocular lens. Okay, the glassy structure, round shaped glassy structure. Okay, this is the optic part. You can see the handle here. This is the haptic part. Okay, this is the handle. So we have to implant this intraocular lens in the posterior capsular bag. So this is the schematic drawing. Okay, so what we do is, this is your nucleus. We have cut open the anterior capsule here. Okay, opening here. You take out the nucleus from here, and what is left behind is the peripheral part of anterior capsule. This is the peripheral part of anterior capsule along with posterior capsule. So this is like a bag. Here we implant the intraocular lens. Okay, so this is intraocular lens. It has two parts. One is optic. Okay, it's the part which helps to refract the light and help you to see. And to support this round structure, there is a handle which is known as haptic. Okay, so it has two portions, optic and haptic. So I'll show you the video. Okay, this is how we do the extracapsular cataract extraction. It's a small incision cataract surgery. Can you see the video? Can anyone answer me if you are able to see the video or not?
Yes, ma'am.
Yes, ma'am.
Okay. So this is how you open up the conjunctiva. So did you see how you open the conjunctiva? This is conjunctiva. Now the conjunctiva is open so that the sclera is exposed. Okay. Now to do the cautery, so all the vessels are okay. Now you give the incision. Okay, this is a partial incision. The prong says 2 mm behind the limbus. Now create a tunnel. Extend the tunnel to 6 to 6.5 mm. Now you have to give the internal incision. Enter the cornea. Okay, and then into the capsule. Now you are inserting this scoop so that the antichamber is maintained. Okay, so you are extending the internal incision in the cornea. Now you have to cut open the anterior capsule. Okay, so this is the anterior capsule. See how it is being removed, the anterior capsule. It's just like peeling off the skin. Okay, so that the peripheral, only the central part is removed. The peripheral part of the anterior capsule is always there. Okay, so you are injecting water, that is hydrodeception. That's how the nucleus is being separated from the capsule. Okay, now you rotate it and then bring it to the anterior chamber. Now with the help of the irrigating victims, okay, you just scoop it out, okay, check it out. Okay, that's how the nucleus is being taken out. Okay. Now the some cortical parts are left over. So we have to aspirate it with the help of irrigation aspiration cannula, okay, which is known as simple cannula. Okay. So see this how we remove the cortical matter. Now whole of the capsule is there. Okay, it's clear. The capsule is there. So in the capsular bag, we are going to implant the intraocular lens. Okay. So this is intraocular lens. That's how we are going to implant it. Okay. See, it's a suture technique. So once the things have been clearing from the anterior chamber, you just have to. Okay, it's a self-sealing hole. Okay, the ball mechanism will be there, which helps you to be a self-sealing. Okay, AC is being reformed. Okay, now just do the cautery in the conjunctiva. So that's how the surgery is being. It's a very safe procedure and the easy technique to see. Okay, though it's difficult to perform. Okay. Now, so this is the surgery of phacoemulsification. Okay, I have not shown the whole procedure, but here you can see this is the phacomacine, phacotip. Okay, it's a phacomacine with phacotip, and this is another. This is a dialer. Okay, with the you need two instruments. Okay, this is how we use the energy from the phacomacine so that the nucleus is emulsified within the back. We don't have to take out the nucleus. Okay.
The nucleus being engaged,
so
dropped
we have
into
to take
smaller
out,
fragments.
we emulsify it into pieces, okay?
And emulsify.
And then make it pieces, okay? Divide into small pieces and then emulsify and eat it up, okay? That's how the pickle emulsification works. Okay, with the help of
Thus the procedure has been.
Okay, so this is how the phaco emulsification surgery is being done. Now we'll discuss on the post-op, complication of cataract surgery. Okay, so in complication of cataract surgery, we'll first discuss on the preoperative complication. This preoperative complication is usually related. Okay, usually it is the anesthesia-related complication. So since we are giving it retrovulvar anesthesia or the peripulvar anesthesia, sometimes the complication might be there. Okay, sometimes there may be retrovulvar hemorrhage. Sometimes the patient may go into shock if the extraocular muscles are being touched. Okay, that is known as oculocardiac reflex. Okay, and then sometimes if we don't go in proper depth, okay, with the needle, we may perforate the globe. Okay, that is, we may perforate the eyeball. Okay, sometimes there may be like trauma in the conjunctiva leading to some conjunctival hemorrhage. Okay, if the weak toenails are very weak and we are giving lots of pressure during after anesthesia, there might be spontaneous dislocation of the lens. Okay. Now we are discussing on the complication of the cataract surgery. We are going to discuss the proper complication, that is intraoperative complication, and what are the post-operative complications. So what complications might occur during the surgery? Okay, so in that video I have not shown you, but in case of extracapsular cataract extraction, okay, in the conventional technique, since we have to give a large incision to clear the field or to make for the better to have the better view, sometimes we have to give the brittle suture in the superior rectus muscle so that the eye is positioned downward. Okay, so what we do is we give the brittle suture. So sometimes while giving the brittle suture, we may lacerate the superior rectus muscles. Okay, sometimes there may be excessive bleeding from the conjunctiva cell, bleeding from the superior rectus, sometimes bleeding from the iris. Okay, so there may be excessive bleeding during surgery, and sometimes there may be incision-related complication. Okay, if the incision is not of the proper thickness, it is too thin. Okay, it may cause buttonholing. Okay, sometimes it's too deep. Then before the corneal tunnel is made, we enter the entry chamber. Okay, so that is premature entry. So at least there has to be the tunnel of around 1 to 1.5 millimeter before we enter the entry chamber. Okay, so if we enter prematurely, then the tunnel is not self-sealing, the wound may leak and it may lead to complications. Okay, it may lead to infections. Okay, so sometimes when we are making tunnel, what we do is we give excessive pressure on the descent membrane, which is posteriorly, and then it may cause the posterior membrane, descent membrane detachment. Okay, so if we give excessive, we are doing excessive manipulation, and if we are giving any trauma to the eyes, it may cause hyphema. Okay, the hyphema may be from the angle structure. Also, if I could like two corner, or sometimes while we are doing the surgery, excessive pressure on the iris can cause the iridodialysis. That is the separation of the iris from the ciliary body. Okay, and then during surgery, since I said in the last class that the posterior capsule is very weak, Okay, so in the posterior pole is very thin, so the patient may have the posterior capsule rupture during the surgery. Okay, the patient, if the posterior capsule rupture is there and we are causing traction on the vitreous, it may lead to the vitreous loss. Okay, and sometimes through the tear in the posterior capsule, instead of nucleus being coming out, it may go back and drop into the vitreous cavity. Okay, sometimes only the lens fragment, okay, few lens fragment may drop into the vitreous, that is posterior loss of the lens fragment. So in post-operative complication, okay, that was intraoperative complication. So post-operatively, what complications might be there? Okay, in post-operative complication, in early post-operative complication, there may be striatal keratopathy, that is, there may be striae in the cornea due to excessive manipulation during surgery. Okay, so we are doing prolonged irrigation or excessive manipulation, entering antechamber too many times. Okay, so all this procedure may lead to damage to the corneal endothelium, leading to the striae keratopathy. So next day in the cornea, we can see all striae all over, leading to the decreased vision. Okay, so likewise corneal edema, so anything, okay, that cause there is an intraocular pressure or excessive manipulation on the endothelium, all this may result in the corneal edema, leading to the hazy cornea, so that the post-operative visual acuity is not good. Okay, so another is prolapse of iris. As I said earlier, like in premature entry, the tunnel is not well made and the wound is not self-sealing. So even a minor kind of straining can cause the prolapse of iris from the wound. Okay, so the wound has to be constructed very well so that is self-sealing. Otherwise, it may cause the prolapse. Okay, prolapse of iris. Okay, sometimes, okay, there may be post-operative hyphema, okay, because there is manipulation in the iris or other structure leading to the hemorrhage, okay, continuous hemorrhage leading to post-operative hyphema. And there is post-operative anterior. Sometimes there may be, like, after cataract surgery, some amount of inflammation is always there. Okay, sometimes with excessive manipulation, or if the patient has some kind of collagen vascular disease or other kind of disease, okay, the patient may experience severe reaction or the severe uveitis post-operatively. Okay, sometimes if the wound is not well made and there's gapping in the wound and the anterior chamber, the aqueous is being leaked, this may all lead to shallow anterior chamber theft. Okay. Another complication is endophthalmitis. The endophthalmitis is the condition where there is infection of the mostly the intraocular space. Okay, the anterior chamber vitreous is all being infected. It's a very dreaded complication, and it occurs usually second to third day after the surgery. Okay, and in this type of surgery, it's a very dreaded complication. It's very difficult to salvage the eye if there is endophthalmitis. Okay, because post-operative infection may lead to permanent loss of vision. Okay, so how do they present to you? They present to you with a severe pain on the eyeball, okay? On the second or third day of surgery, they come to you with a severe pain and there is edema of eyelid, chemosis, okay? And then there's decrease in vision and there's corneal haze, the patient has developed hypopia and there's severe inflammation and even the glow is very dull. I know it means that there is some kind of exudate in the vitreous. That is, then you have to diagnose that this is the case of endophthalmitis and it's a very serious condition. Okay, it's a very serious condition. It's an ocular emergency. Once you diagnose the case of endophthalmitis, what you have to do is you have to go for immediate treatment. Okay, just take the patient to the OT, give him the intravitreal injection of antibiotic, give him a systemic steroid or corticosteroid. Okay, so depending upon the condition, we may need past planar defectum to removal of the infected vitreous. Okay, so ultimately, if we cannot salvage the eye, we may land up in evisceration. Okay, evisceration means we have to remove the eyeball or the eyeball content as a whole. Okay, so it's a very dreaded complication. So this we have to know what is endophthalmitis. Okay. in late post-operative complication, okay, which occurs late post-operative means it may occur after the weeks of surgery or months or years of surgery. Okay, sometimes the patient may develop secondary glaucoma. Okay, sometimes if there's persistent like corneal edema, patient may develop bullous keratopathy. Okay, if there is persistent inflammation, it may lead to cystoid macular edema. Okay, and later on, some every patient may develop some amount of posterior capsular opacification. Okay, and then if there is some traction of vitreous during the cataract surgery, the patient may develop retinal detachment later on. Okay, and then there's chronic uveitis, and sometimes there may be late endophthalmitis as well. Okay, mostly the fungus can cause late endophthalmitis. So you need to know what is after cataract or secondary cataract and or PCO. Okay, sometimes we call it posterior capsular opacification or PCO. Okay, another name is after cataract. Some says it's a secondary cataract. Okay, so what is PCO? It's an opacity of posterior capsule which occur after cataract surgery. Okay, it's not a complication. I won't say it's a complication. It's a normal physiological phenomena. As you know that in lens, the lens endothelium epithelium, they are undergoing mitosis throughout the life. Okay, so lens fiber are being formed throughout the life. So what we so even we remove the cataract, even we remove the cataract, since the capsule are left behind, the capsular epithelium, they undergo mitosis, and then the lens fiber are being formed, okay, and then they are laid on the posterior capsule. They are leading to the formation of posterior capsular opacification, and there are two types. One is shimmering ring type. That means there is a thick ring of opacification between the two layers of capsule, between anterior and posterior capsule. There is thick ring is being formed, and another one's arsenic pulse. Okay, these are the baculitic type of epithelial opacities are there along the posterior capsule. Okay, so you can see that baculitic subcapsular epithelial cells are like clustered, and then they are clustered like a soup bubble along the capsular cataract. Okay, in the post in the posterior capsule. Okay, these are known as a snake pore. So once the opacification has developed, what we have to do is that since the light won't be able to pass through this opacity, now we have to make another opening. Okay, so that the light can pass through the lens. So what we do is we make an opening in the posterior capsule, and this procedure is known as capsulotomy. Okay, so capsulotomy means that we are making an opening on the capsule. So how do we make this opening? Okay, we don't have to take the patient in the surgery table. We can use the laser, and the laser we use is ND-YAG laser. Okay, so with the help of ND-YAG, we do the anterior YAG laser capsulotomy. Now we are going to discuss on the surgery for congenital cataract. Okay, for congenital cataract, it's very important and it's very crucial that the patient has to go for the cataract surgery. Okay, so once the cataract is being diagnosed in the child, okay, if the cataract is unilateral, we have to operate as early as 6 weeks. Okay, within the 6 week of life, we have to go for surgery. We can't wait because the patient may develop amblyopia and they may remain blind forever their life. Okay, so in case of bilateral cataract, we may wait up to 8 weeks, okay, but not beyond that. Okay, and the prognosis is good among the patient with bilateral cataract, which is unassociated with nystagmus. Okay, the unilateral cataract has bad visual prognosis because there is always a competition with the good eye, and so there is always the chance of developing amblyopia in the cataractous eye. So what we do, the method is that the method of surgery is different than that of the adult surgery. Okay, in adult, the nucleus is very hard. Okay, so we have to extract out the nucleus. But in case of children, the nucleus, the lens fiber are very soft. Okay, So we don't need to take it out. Okay, just we may just aspirate it. It's just a liquefied thing, so soft and so liquid like a thing. So what you do is just aspirate it. So the procedure is lens aspiration. But since the capsule of the children, they are mitotically very active. Okay, they undergo mitosis very rapidly. So there is always the chance of being of the chances of the posterior capsular opacification is very high. It's very rapid among the children. Okay, even the anterior vitreous may undergo opacification in children. So what we do is in these children, since they are not able to sit on the slit lamp, so that we can do laser capsulotomy. So what we do is we do on the table surgery table itself. We do primary posterior capsulotomy on the same sitting. What we do is we make an opening in the posterior capsule along with anterior vitrectomy. Okay, make an opening in the anterior vitreous as well. Okay, so that later on the opacification won't be there after cataract surgery. So whether or not to implant the intraocular lens depends upon the age at which the surgery is being performed. Okay, since the children they undergo surgery under general anesthesia. Okay, for adult we can give retinal block, but children we can't give block. Okay, so for those children we have to go do the surgery on general anesthesia. And whether or not to implant the intraocular lens depends on age. Okay, if the children is less than 6 months of age, okay, then because of the other complications related to it, okay, there's chances of severe infection, and always there is the refractive changes are going on in the children because their eyeball is not fully growth, the curvature is being formed. Okay, so we don't implant the intraocular lens in the children before the 6 months of age. But then if the child is more than 6 months of age, then we can implant the intraocular lens. Okay, sometimes to aspirate the lens, we can use the phaco machine to aspirate it. So this procedure is known as phaco or aspiration. Sometimes we can go through the pars plana approach, okay, from the pars plana, that is the uveal tract. Okay, so we use to that approach, we can remove lens as a whole. That is known as pars plana lensectomy. Okay, so these are the procedure which are done for the congenital cataract. The first one is lens aspiration with primary posterior capsulotomy and anterior vitrectomy along with posterior chamber, along with or without posterior chamber intraocular lens implantation under general anesthesia. Okay, this is the most preferred technique. Then other techniques are phaco aspiration and pars plana lensectomy. And the complications associated with congenital cataract surgery is very high. There is always chances of amblyopia if visual rehabilitation is not early. Okay, then the patient may develop amblyopia. Okay, and as I said earlier, the rate of PCO is very high among the children, and since in children the inflammation, okay, the inflammation rate is very high in children. So in children, only topical steroid is not in adult. What we prescribe post-operatively is that we give post-operative antibiotic, we give topical post-operative corticosteroid. But in case of children, the topical post-operative steroid is not enough. We need to give them systemic steroid as well because the inflammation rate is very, very in the children. Okay, and then always there is chances of secondary glaucoma is always there. And since we are touching the vitreous in case of children, okay, we are doing the anterior vitrectomy. So we are touching the vitreous, so always there is chance of retinal detachment among the children. And then since if the child is of less than 6 months of age, and then we have removed the lens and we have not implanted the intraocular lens, okay, in those children, then the children are aphakic. Okay, so if the children are aphakic, we have to give prompt correction of post-operative aphakia. Okay, we have to give the treat the ophthalmic patient promptly. No, because if we don't give ophthalmic correction on time within a week after surgery, then patient will develop the amblyopia. Okay, so we don't want all the effort to go in vain. Okay, so we have to give them early visual rehabilitation. So the ophthalmic correction can be done with spectacle. Okay, in Nepal is the most preferred technique because in in developed country they use contact lens, but due to hygiene due to the concern of hygiene and the technique involved. Okay, so in Nepal, most parents they don't prefer to use the contact lenses. So we give only spectacle correction. But in developed country, they use contact lens. So once the child is of 2 years of age, okay, then we can go for secondary intraocular lens implantation. Okay, so that's all for today. Okay, that's on the management of cataract. This is very important cataract. This is very important topic for your exam point of view. You may have questions on SAQs, even on MCQs. Okay, and then PBQs also. And most importantly, it's very important for you in the practical examination because invariantly you are given the cases of cataract in long cases. Okay, mostly you will get the case of cataract in during your practical examination. Okay, so